كيف امورك؟
الحمد لله
بخير؟ كل شيء تمام؟
زعلان عنك.
صعب الله عندك العافية ان شاء الله.
اكيد وقت الغداء
لازم ان شاء الله نجي ان شاء الله يوم نسلم ان شاء الله.
في مستشفى.
اكيد.
والله.
السلام عليكم ورحمة الله وبركاته. To start our GI club today, the KFC is presenting. We have two cases. First case we present by Dr. Balawani, our senior assistant. The second case will be presented by Dr. Ilan Makir. So this is the type of our case. We will take it as usual, basic examinations, brief, report, and then suggestions, differentials, typical them. Sorry.
My name is Mohammed Abdullah Wali. I'm presenting the case today. This is an unusual case of a teenager presented with jaundice and spinal problem. This is a 19-year-old female who is single. She's from Nina Nova, student, with no previous significant medical history. anybody wants to know any other thing in the history.
So thank you. So now we get like a summary of the solutions. If you have any questions to ask.
This is first time.
Yeah, this is the shortest history, 4 books, and she never had any other issues.
No history of diarrhea or chronic diarrhea.
No.
This abdominal mass was it cystic?
No. It was full.
The mass tender mass? Tender?
No, it was not.
Yeah. Lymph node?
No lymph node.
So at this stage, like in the previous examinations, previously there was no jaundice. So like 4 weeks.
Yeah, so jaundice history was only 4 weeks.
She was completely free from physical diseases and she was well.
Because she had days to get over the pruritus. So there is evidence that she's really prosthetic mainly, or in the history at least, by the bills to the pruritus and so on. Yeah, she's bailed, that's a possibility, maybe some evidence of pruritus, but mainly it looks like prosthetic jaundice.
So any differential diagnosis at this stage, or we can proceed to investigations? Yes. So differential diagnosis from the fellows here.
Lymphoma.
Because of a very short period, I think obstructive jaundice is one of the differential here with CBD stone or other stricture, period stricture. But there is history of diarrhea, maybe we can consider also BSC here, you can say extra biliary causes, so maybe something obstructing from outside, or maybe there's something from the biliary cells. Also, this likely pregnancy here.
We have the possibility of autoimmune receptor IgG4 with masses sometimes happen like that, or any liver tumor can happen, which is stone or something. The age is slightly late for that, but can.
So now the differential diagnosis, like lymphoma, cyst, like autoimmune disease, obstructive jaundice, like liver stone, and obstructions, hepatitis, liver abscess, maybe it's a 4 weeks differential diagnosis.
The pain is
Yeah, it is not unlikely.
I mean, the pain he mentioned is 4 out of 10. It's not really the history of the story. And this is like progressively, slowly, and so on. So I think the stone is, my history at least, is unlike, yeah, there is some sort of prosthetic, there is some sort of maybe obstruction. I don't know whether they feel this is like the gallbladder, is it, you can get above this mass, or is it the gallbladder above before? So you have to keep it correction that there is some sort of mass compressing into the CBD or somewhere, and that's causing the
As on examination, the mass was not cystic, so unlikely it was gallbladder, and the patient had a mass, so unlikely to have a CBD stone. That's what Correlation is law.
So this is the point. Like mass with these symptoms, CBD stone, unlikely, hepatitis, unlikely. So we have to think about something like with the differential diagnosis of this gastric disease. So lymphoma was mentioned.
Sarcoma out.
Sarcoma,
Biliary TB.
tuberculosis, possible. So let's get the initial work and then we'll continue the differential diagnosis of this case.
This was the workup the patient was up, and CBC revealed that she is having anemia, hemoglobin about 8.6, and nothing much significant other than that. And in the local history, her bilirubin was around 160, which was mainly direct. And alkaline phosphatase was high, IgG was high, little increase in the ALT, AST, borderline albumin, LDH high, amylase was normal, kidney function is normal, SOS normal. Next, hepatitis B, C serology was negative, HIV was negative, IgG4 was down, and coagulation profile was down. So what are the possibilities?
So anemia, she had sort of like 8.6. She got like high row 127. AC and T like borderline isolation. And Blazers no. Yeah, it was wrong. And IgG4 dash 4 is good. So we'll think about the same differential diagnosis. What's next? Ultrasound. Yeah, we started with the very basic. The ultrasound was done, which actually had two findings. One was that there was some lesion at the porta hepatis, and pancreatic had some hypogenicity. Can you go back to the image? Yeah. So this is the basic. Yeah, this one is showing this pancreatic head and the CB, and there is porta hepatis and mass liver. It's not well shown here. In the next slide here, you can see it. And there's some other region also in the liver parenchyma. So we have three findings here. One is that this patient has a porta hepatis mass as per ultrasound, and there is some hypoechogenicity in the pancreatic head, and there's some blood specific, like a change in pancreas, small protein in the liver. Next we proceed with the blood measures and ultrasound. We did the CT abdomen. So ultrasound was required as there's a large mass of pancreas. So try this. Is there any possibility of SCC here? Yeah, so 19 years old, no cirrhosis.
Yeah. The National Guard has presented some of these that up to even younger, like 14, if I remember, they presented some sort of fibromyalgia, carcinoma. It can be like this. So, yes, even in non-cirrhotic. So, have to keep it in mind. I don't know what's happening for protein. I think it was normal, protein or something.
Yes, it was not.
That does not really explain the pancreatic head.
No. It's not specific. That's why ultrasound gives us like an clue, but we did the scan. So it's a scan. So next we proceeded with vector imaging, which was a CT. Again, if we see in this image, there is some lesion in the porta hepatis area, a similar one. This is again the same. Actually, CT was reported that there is a large mass within the porta hepatis, which measures 7.7 to 3.3 centimeters, and is causing obstruction to the moderate intrahepatic dilatation. And there's another mass surrounding the gallbladder and segment 6 of the liver and omentum. It's around 4 into 8 centimeters. There are multiple hypotensive liver lesions scattered throughout the liver parenchyma. Pancreas displaced by porta hepatis mass, however, pancreas was absolutely normal. There are multiple outer here or enlarged lymph nodes. The largest area is 1.7 centimeter at short exit. And this patient had peritoneal deposit within the right mid abdominal omentum, measuring about 1.5 centimeters. So this is like a more clear findings in the scan, multiple lymph nodes, porta hepatis, large lesion or mass, intrahepatic dilatations with the peritoneal deposits from underlying. So I recommend
TB or lymphoma? TB, lymphoma.
Do you have any about that?
It's unlikely this big in this size.
10 years old, there is no risk of any biliary malignancy, no IBD, not diagnosed with an IBD.
The location of the mass.
The problem is multiple lymph nodes, porta hepatis, is a lymph node with the intrahepatic dilatations. The extrahepatic was not that dilated and that was not restricted. No, I mean, there was good restricted. Okay.
Very aggressive. This looks like aggressive tumor.
So what kind of tumor?
Could be lymphoma, could be
Alpha-fetoprotein was not
normal.
Yes.
And the lung, CA, and what is it?
Lymphoma.
And the H was down.
HAC.
LDH, mild elevated.
LDH might be elevated. This picture typically of lymphoma, but we need histopathology.
What about tuberculosis? TB? Possible?
Yeah, possible.
Young age from Medina Munawwara, well fit, all vaccination given are family abnormal, unlikely.
Likely to be
It could be, anything could be.
Likely to be lymphoma, what else?
Sarcoma is also possible. Sarcoma is very aggressive disease. So we don't know.
Yes, it's possible to be like a solid malignancy. So what kind of malignancies?
Neuroendocrine. Good. We had one like that.
So neuroendocrine tumor, maybe the chain of pancreas is some
It's
pneumonitis.
not like this, much more like this, because usually this
Just proceed for myopathy.
So what's next? So we'll do MRCP, MRI, or ERCP, or EOS.
Histopath.
So next step.
Histopath.
What we did next, as we found that there is some mass in the food apparatus, so it was mandatory to scan this patient but further look for the other places. So we went ahead with a CT chest. The CT chest showed that there are multiple scattered pulmonary nodules in both lungs, and there are some saturated lymph nodes in the right retrocrural and right subcranial carinal areas, measuring about 7 mm. And there's a left spatulary leukocyte measuring 1.8 to 1.8 centimeters. And there was wide flow between the left side. And then we did CT neck as well. The way everybody's mind had an option of limbo muscle scan, we do have the same. So we went ahead with the CT neck, which did show that there's enlarged lymph node in the left scaling area, level 4 measuring 90 into 18 millimeters. Otherwise, numerous subcentimeter lymph nodes in the neck of both sides. And the normal outline of nasopharynx, oropharynx, and laryngopharynx. So now, how should we proceed?
Lymphoma and TB, both.
What's next? To do like an
Lymph node excision biopsy.
to show like an AOS, by AOS or by images. What other low? Endoscopy. What about the RCP, sheet jaundice and mastectomy?
You can't do it by RCB. This is, if you go, you will go for BTC or something. But I think the best in this patient is not having cholangitis. You need to know the diagnosis. And maybe once you know the diagnosis, keep it out or something, subside these masses. You don't need anything to relieve your obstruction. Whatever chemo or the underlying diagnosis is given. Unless you develop this cholangitis. At that stage, I will go interfere for BTC or I don't think your RCB will reach that.
But the problem with this patient was that she had only small liver lesions. The money was like multiple large lymph node, very pancreatic, abdominal,
And the
gastric.
Bottis mass.
So the liver lesion was very small. So as routine, what we proceeded with upper urology endoscopy and both were normal. And then we decided about going ahead within EOS. So the version of that was initially was lymphoma. So the patient was referred from Medina as like a pancreatic mass for metastasis or lymphoma. So the impression is the most likely was a lymphoma. She had multiple lymph nodes and accessible, large. So we get like all the whole work up, and then we have to proceed by EOS to take POCOR and FNA because the liver lesion was very small. So EOS was done.
Yeah.
The ERCP.
Yeah, EOS, we took sugar biopsy from the hepatic region as well as we took one of the lymph nodes in the portal hepatitis. And similar to the findings that there is some mass in the portal hepatitis. And the hypotenuse lesions in the liver. This was EOS finding.
And multiple large.
So we went with a therapeutic region and we did diagnostic, we took the biopsies and we took the FNA.
So we did EOS and we could look at biopsy and FNA. And at the same time, what about lymphoma? We still have to deconverse her biliary tree because most likely she needed chemotherapy and then for an oncologist or for a hematologist. So she underwent the ERCP.
So next to the QS, we went ahead with the ERCP and this is the finding.
Can you lock the lock? It's really difficult really in there. Try to reach that area.
Next. So I comments about the ERCP imaging.
Dilatation.
We get regular
Smile in the BD.
this area will be.
How powerful is it? Be careful. This is the part.
No,
Double wire.
Yes. I agree. That's the expert thing, you know. It was very difficult to ask me.
لا لا صحيح. لا ما شوف سد الباكلاس عشان يقدر.
So we, as information was very difficult to ask from the beginning to generate, so we used the wire and the wires and the wires clear and back. And then we will generate chain restrictions in this area. It's like an upper part of the common event. And we cannot go minimize the distal part of the CBD with intra-hepatic dilatations. Because of the capillary pressure was not careful, so we did stent dilation and also we did the pancreatic stent for the pancreatitis, and then we did the biopsy result from the lab.
Dr. Ali, is this right system normal or there are some dilatation and
It was
the right?
yes. There's a restrictions intra. Yes.
The right is not really visualized.
Yes.
Is there any atresia in the biliary system? Some atresia? It's not
So we have no restrictions. So like
Dilatation, there is
also
dilatation.
intra-hepatic with dilatations. Yeah, proximal dilation.
You visualize here only the left. It's the left.
The left part and the part
The right one is not really visualized.
Yeah, yes. We have to dilate right now. So what's the visit? It improved, and then this is post-stent, we put a stent. And now what's the feeling after seeing this ERC picture and US changing over my
It is external compression for the area.
but you had about also restriction.
Cholangiocarcinoma?
Yeah, there's no background BC, but we think when we one of the possibilities we cholangiocarcinoma with the background with BC without BC. So why was it?
So yes, as the audience had in mind, similar way we also actually sent the investigation, further investigation, which included the tumor markers. And interestingly, we found CA 19.9 as high as 268.3. With the normal CA, with the normal
Is it specific?
No, it doesn't much tuberculosis. We see CA99 is not really that specific when you have tuberculosis.
So, can we do elevate for malignant disease?
Yeah, actually, the patient had cholangitis and it didn't have much significance. But in the absence of cholangitis, we have to take it with a pinch of salt because exceedingly normal pregnancies. So we did FLA during US, and the result came as intraoperative efficacy statement was indicated and general diagnostic entry, medical cell identified cytology diagnosis, cytomorphology consistent with poorly differentiated malignant neoplasm. Whereas the biopsy came as poorly differentiated adenoplasma and immunohistochemistry CK was high, it was positive, cytotherapy was positive, whereas the rest were negative, and this patient had a very high Ki-67, very highly proliferative invasive tumor. So, our opinion, heightened cholangiocarcinoma, Klatskin tumor, metastasis to lymph nodes, liver, and lungs.
How many years like this went without any clear structure? So surprising how they will get planned for the beginning.
But you don't see, it's not really classical classic when you face both the dark.
It's not involving both intrahepatic ducts. So there is one of them. So by this one, it's somewhere similar.
This is adenocarcinoma, maybe like the cholangiocarcinoma.
Yeah, maybe cholangiocarcinoma.
Or unknown primary. Sometimes you get something unknown primary.
But in case of unknown primary, they would not, they would say it's metastatic adenocarcinoma. They would not say that it looks like primary. And we have done the
most of the times unknown primary, you look in the ovary, in the area of
true, but the genitals were wrong.
Yeah.
We didn't
get any proof for any other treatments. Now to support this opinion of this cholangiocarcinoma, there is a lot in the literature. Usually we know that median age is 50, but there are cases when cholangiocarcinoma has been seen in adolescents. And this is one of the studies. This is cholangiocarcinoma in young individuals with and without primary sclerosing cholangitis. So there were many young adults found to have cholangiocarcinoma despite absence of PSC. And the young group of cholangiocarcinoma, they had a similar fate as we have in the older age groups. This is another study, recent study 2 years back. 17 patients with cholangiocarcinoma in young adult workers of printing company in Japan. These patients had exposure to the chemicals, but we know cholangiocarcinoma at times we won't be able to find any etiological evidence without any respect and etiology. Patients can develop cholangiocarcinoma. But in this case, they had an exposure to chemical. It was dichloromethane and 1,2-dichlorpropane. And one more case report of intrahepatic cholangiocarcinoma in young male who was addicted to heroin and with methadone, but no etiology was found, so they concluded and they correlated with the use of chronic use of heroin and methadone. So there are many cases in literature where we have cholangiocarcinoma in young age as well. So regarding cholangiocarcinoma, as we all know that it originates from the intra and extrahepatic epithelium. And historically, it was around Hardy, 1840, who came up with this entity. And hypercholangiocarcinoma, the specific entity, was described by Klatskin. That's why we call it Klatskin tumor nowadays. And we know that they are very rare tumors. They comprise about 3% of all GI tumors, but they are the most common, second most common primary hepatic tumors after hepatocellular carcinoma. And the worldwide average age is 50 years, as we discussed earlier. And in Western nations, it's even more, it's around 65. Very rare to have it less than 40 years of age. These are the two classifications. The one is, we all are aware of this month, and the newer one is which classifies it into intrahepatic and extrahepatic. And extrahepatic may consider hyper and distal, which includes the CBD involvement. So intrahepatic and extrahepatic. And this is the distal classification where, according to the location of tumor in relation to the bifurcation, we have around 4 types and 2 subtypes of type 3. And risk factors for cholangiocarcinoma, we know first is PSC, another in Asian countries, Vietnam, China, liver flus, hepatitis is secondary to oriental cholangiohepatitis. We know that Crohn's disease, congenital hepatic fibrosis, multiple cysts, as somebody in the audience said, viral hepatitis B and C infection, liver cirrhosis, and chemical compounds, mostly holocaust, which are here used as a contrast agent. Obesity and diabetes have been also correlated to the risk factor of cholangiocarcinoma. But it's not definite. False. It's in the probable group of classification, not the definite one. These are the definite ones. And regarding CA19.9, we just had a discussion, so I found this slide to be discussed here. This is the currently most common tumor marker used in this situation. But it has 2 limitations. One is the Levy's phenotype. We all know that around 10% of population have Levy's phenotype. That means they will have absent CA19.9 despite any malignancy or any other thing. So this is the one drawback of CA19.9. Another drawback, as said in the audience already, that it's elevated in other GI and gynae malignancies and bacterial cholangitis. But a CA19.9 level cutoff more than 129 has a sensitivity of 78.6% and specificity of 98.5%. And cytological analysis in cholangiocarcinoma. Tissue diagnosis is usually obtained by flash cytology or by gut biopsy during ERCP. The sensitivity and specificity we know is very low, it's around 27 to 63% and 89 to 100% respectively for the breast cytology. And the limitations for cholangiocarcinoma are this tumor is usually dysplasic tumor. That means the tumor has an abundant connective tissue, fibrotic tissue. So at times, even if you take biopsy
decided until the advanced stages. We know this thing. And once symptomatic, clinical presentation is dominated by the anatomic location of the tumor. The predominant clinical feature of extrahepatic cholangiocarcinoma is video obstruction, resulting intrahepatic usually presents with painless jaundice, and extrahepatic usually presents with pain. This is the common presentation of these. 90% of extrahepatic, they will have painless jaundice. And intrahepatic presents in most cases as a mass, causing right upper quadrant pain and tumor-related symptoms like cachexia and malaise. And approximately 10% of patients with cholangiocarcinoma, their first presentation will be colonoscopy. The role of systemic chemotherapy is evolving with such patients. We know that benefit of chemotherapy over the best supportive care has been suggested in one small randomized trial, but there is no single chemotherapeutic agent or combination regime which consistently leads to objective tumor shrinkage or recurrent force cause of recurrent obstruction, or does extend the survival beyond 8 to 15 months. Surgical resection or liver transplantation is the only potentially curative therapeutic option. Photodynamic therapy can be valuable for unresectable but localized cancers, and in the future, targeted therapies have the potential to extend life for patients with advanced metastatic disease. Here I can say allergic manuscript, the latest one being used is erlotinib. And contraindications to do surgery in the cholangiocarcinoma case is the patient has reduced bilobar involvement, he has peritoneal vasculosis, distant metastasis, underlying liver disease, and if after resection the future liver will be less than 20 to 30%, or severe comorbidity. Surgical resection with curative intent is the treatment of choice for cholangiocarcinoma. Although the rate of treatment is only 65%, and curative resection or margin-free rates are only achieved in 50%, even less than 50% of patients. And 5-year survival after the surgery is 23 to 63%. 5-year survival rates are 30 to 41, and as per classification, higher is 30 to 40, intrahepatic is 31 to 60, and extrahepatic is 27 to 37. Mortality rates of resection are 5% to 10%, even in major metro hospitals. And new adjuvant strategies including chemotherapy, radiation, combined radiochemo, photodynamic therapy has been used. But there is currently no adjuvant therapy which is recommended in the guidelines. Finally, transplantation. Initial results for extrahepatic cholangiocarcinoma were very disappointing. 5-year survival was just 23 to 26%. And recurrence was very high, more than half of patients had recurrence. And based on these outcomes, initially nobody would suggest to go for a liver transplantation in such cases. But later, with the new adjuvant strategy, there are promising results. What they do, they use external beam radiation with 5-FU, followed by brachytherapy and pierce infusion of 5-FU before liver transplantation for extrahepatic cholangiocarcinoma. And these are the exclusion criteria where a patient cannot go for transplant. It includes uncontrolled infection, prior radiation or chemotherapy, intrahepatic metastasis, extrahepatic or distally prone metastasis, other malignancies within 5 years of cholangiocarcinoma, age more than 65 years, comorbidities forbidding chemo or radiotherapy or liver transplantation, and higher mass and cross-sectional imaging with the radial damage of more than 3. These are all contraindications to go for a transplant. Thank you very much.
So the lesson of this case, what the arrangement is all with the presentation tend to be like another cholangiocarcinoma. Any comments before we do the next case?
Thank you for this extensive review, a very nice case presentation. It was excellent. I just one thing to ask, only for my information. Did she ever have an MRCP?
Because she was completely asymptomatic like a month ago. So short with history. I think she had an ultrasound. She didn't get around that bus. She was completely asymptomatic. Just like in a 4 weeks.
Why you ask this question? What does you have in mind?
What's there
It will show you the restriction, it will show you the area of obstruction, it will help you. I think that will be, in this case could have helped you in making a diagnosis.
If this patient had an IBD, yes, he probably still had a risk of chronic carcinoma or BC, but she didn't have any problem.
This is so advanced. the beginning of the tumor, some people they use brachytherapy, which is you put brachytherapy through the RCB, that area to some surface, yeah, and then you go for surgery.
You need to downgrade the tumor.
Yeah, and also improve their result.
No comments? Thank you, Abdullah. So next case, Iyad Makki present and with Abdullah.
Our second case was presented by Iyad Makki, who is one of the competent in Saudi directorship program, and enjoy the presentation. We will discuss this later. You cannot hear me?
Assalamu alaikum, good evening everyone. Our second case today, she's a 44-year-old female patient, not known to have any medical illnesses before. Patient presented to our hospital with 1 week history of abdominal pain, nausea and vomiting. Abdominal pain was on and off for a few months, but got more severe and more progressive over the last week before presenting to our hospital. The location of the pain was unspecified generalized abdominal pain, diffuse, colic in nature pain. Vomiting started 1 day before presentation, but no hematemesis or meaning associated. No history of fever, weight loss, or change in appetite. No history of a change in bowel habit. No history of aspirin or NSAID use. No history of biliary disease before, and no history of similar condition before. Patient is not known to have any medical illnesses before, and no previous hospitalization. Not known to have any allergy, and not on any regular medication. No single condition in the family, and no chronic illnesses in the family. She is married, living in Riyadh with her family, non-smoker, alcoholic, or IV drug abuse. Systemic review was unremarkable. Our patient was sought medical advice in the hospital, seen by a physician. Her examination was mainly hemodynamic was stable, abdomen was soft, but tenderness, deep palpation, diffuse in the abdomen. Her initial labs, which showed WBC is almost normal, only platelet was slightly elevated, sodium just a little bit in the lower side, and inflammatory marker were high. Bedside ultrasound done by the ER physician, which was unremarkable. So the patient went for CT scan, which was circumferential segmental wall thickening involving the iliac loop, mainly in the submucosal, and involved segment exhibit wall enhancement, but no mucosal sloughing. The affected iliac loop exhibit mild dilatation with no sign of obstruction. Here, as we can see, the thickness almost 6 millimeters of the bowel with some dilatation. So the patient was referred to our department GI, and upper endoscopy were done for her, which was normal result. Colonoscopy, including terminal ileum, also were normal. Biopsy were taken for histology, acid-fast bacilli, CMV, and cultures, all were normal, negative. So patient was managed initially with by the surgical team with a conservative management. Few days later, she was feeling better, and her symptoms was improved, and she was discharged. 4 weeks later, the patient presented to the ER with the same presentation, abdominal pain, nausea, and vomiting. The workup almost the same with a high inflammatory marker, CRP and ESA. The previous labs, the biopsy were taken, everything came to be negative, including AFP and CMV and the biopsy of the terminal ileum. Quantiferon was done, the previous admission came to be negative, ANCA, ASCA, and ANA were negative. CDX serology also came to be negative. So repeated CT scan again, which showed segmentally thickened small bowel loop, even increased than before, with some improvement of the surrounding fat strand. Again, upper endoscopy were done for her, which showed normal result. Colonoscopy done, which showed mild erythema at the terminal ileum, but otherwise normal. Biopsy were taken for histology, acid-fast bacilli, and CMV again. Small bowel follow-through were done for her, which showed the proximal lobe of the small bowel, which was mild mucosal thickening with no structure or ulceration. The iliac loops appear normal with no evidence of stricture or ulceration. No fistula were seen. So the patient went for double balloon, which showed mild erythema in the proximal part of the jejunum. Biopsy taken, the whole came to be negative. Again. She was managed again with a conservative management, and few days later, she felt much better. Her symptoms improved, and was discharged and given appointment in our clinic.
So at this stage, what do you do with this patient? She keep coming and presenting the same finding, CT finding, abnormal CT findings, significant symptoms, but the gastroscopy, coloscopy almost normal with negative biopsy, serology, all the workup normal. And she just had the symptoms, and few days in the hospital she improved, and her symptoms improved, and
You work up for vasculitis.
yes, yeah, negative, all the workup. Selected. All the biopsy back to be normal, select serology negative. Yes? Yeah, but we have done, the biopsy is negative. So that's why I present this patient, and I left the discussion until you have the...
There was either inconsistent result between the small bowel and the CT scan, or you mean its result?
You mean?
CT scan, there is a significant because of technique.
Yes.
It is small bowel, or I understand it was not, sir?
No.
There was thickening.
There was thickening. There was thickening.
Mild, whatever, but there was no stricture, there is
No stricture. No stricture, and the biopsy is...
How far did you go?
I'm not sure, but because I am not the one who did the procedure, I come across this case later. But I'm not quite sure. But they find some erythema and little abnormality. But the striking thing is that the biopsy is normal. You have significant symptoms: nausea, vomiting, abdominal pain. Definitely, she had something. Her bowel is abnormal, and she keep coming. Yes, but the biopsy all negative.
Still there. Crohn's disease is still possibility. Like if we're thinking something resolving, then you have to think of this very rare.
What's her nationality?
It's Saudi.
Angina, nothing. Probably I would have to rule out
To what? Cycle?
Yeah, Mr. Cycle was unrelated to the herpes.
No. Why you ask about the cycle in correlation with this presentation? Okay.
Endometriosis maybe.
Think about that. See what space inhibitor did you do it or something? I think angioedema is a possibility because everything is negative in your finding or whatever biopsy.
Yeah.
So this way you get something, bots comes in bots and resolve. Go very with the angioedema.
So what
Just do this one stage and see what happens.
if it come back to be normal?
That's fascinating.
Professor, let me ask about the capsule. Any capsule?
I think no capsule will be that
Because
one.
every now and then she come with dilatation, we thought maybe she has some obstruction or something. So
Yeah,
we
because
It did the variable.
It's not about didn't show stricture. So
I think I'll go with industrial.
Crohn's should be ruled out.
You can go with
If
the.
not, then I will go with
But-
the porphyria, with the angioedema, with those very unusual.
What the capsule endoscopy is going to add at this stage, definitely I have something abnormal.
No, but you didn't demonstrate that abnormal.
It's abnormal in the CT.
No, this is the
And reached by double balloon.
If the capsule endoscopy showing the degeneration down there, then I'm sure that we are dealing like this.
Okay.
Then I'll go home with level of alcohol, then I have to rule out lymphoma, all this.
Yeah, but the double balloon was done and biopsy was taken.
We know that, we do keep
No, reach the abnormalities.
No, mid-jejunum maximum, distal jejunum.
No, it has been the biopsy being taken. But I
If you reach that
The area, yes.
The development was reached that normality based on the CT scan. But it will continue because the rest of the bowel is normal.
With the capsule first, show your
But
If you want to with the capsule, go there.
also,
To correlate it with your double ballon.
also, she had involved her terminal ileum by the imaging, and biopsy was taken
And eosinophils, everything was fine.
normal, all normal. Anyhow, we will continue.
So our definition was made with Crohn's disease IBD in the top of our definition initially. Infectious process TB, CMV, celiac disease with complication, eosinophilic gastroenteritis, vasculitis, any vascular event, liver disorder.
So we looked at all these things and undermined. We failed to prove any of these. I'm not quite sure, but why just pain and angina? Okay, but edema, thickening, and
It doesn't show the thrombosis in it.
no, there's no evidence here, and the radiologists keep telling that there is no evidence of bowel skin. No lymph nodes.
Yeah, not the first diagnostic, it's not panicolitis.
But I think it will be classical on CTE or small bowel edema.
We call something collagen colitis or.
But how you will
I have not seen.
No, I'm giving you the scenario now that biopsy is normal.
Yeah.
Everything is possible, but what you will do in this
The
situation?
next step is the diagnosis. You may go from a hospital and full thickness labs. Period. You get the diagnosis.
Before you go any
You will do your all things again, and maybe you meet the double balloon if you want, it doesn't matter. But if you didn't get to reach the diagnosis, you may end up to go for full thickness labs and get the result immediately. And that's it.
Laparoscopy.
Laparoscopy, yes.
Diagnostic.
Can be considered
So, I cannot hear you.
familial renal fever.
Yeah, it's very fever, but
She
this
doesn't have
is
fever.
indication. No fever.
If there any relationship to menstrual cycle, maybe a migrating endometriosis can be considered. If there is any relationship to menstrual cycle, migrating endometriosis.
Yeah, but with this all finding now, you are giving me suggestion, but if you are in my situation now, what you will do? If it is endometriosis, as you said, what you will do or to exclude?
No, endometriosis is the history.
History to menstrual cycle, vaginal pain,
Yeah, if there is,
But
let's say, let's say there is history, so what you will do? With all these findings. Yes?
I think it will depend on how much convinced from the imaging. Are you convinced that this imaging is abnormal? If you're convinced, then you need to go probably for a capsule, and if it's normal, then I need a full thickness biopsy. And full thickness biopsy will not be able to do it by just endoscopy. So I agree with it. Probably endoscopy will be an option. But the question, are we convinced that the CT is abnormal or not? Because not subjecting a patient for laparoscopy will be a big deal.
Because according to the finding now, according to CT scan, significant thickness.
Much edema from the balloon.
I'm not sure how significant.
You get some mild edema from
Okay,
our balloon.
just let's
Take us history, we see
we will go through and see.
We do some mild edema.
Okay, 5 months later, the patient presents again with the same presentation, but this time with severe abdominal pain, nausea and vomiting. CT which showed small bowel dilatation with small bowel obstruction. The thickening again was seen again with the definition was really vasculitis and ischemic events. Interval, there was development of mild ascites, but major persistent Here is a picture with the dilatation and
Looks like pseudocyetes.
so the patient underwent surgery with the resection of that part, the proximal part of the jejunum, and also with the terminal ileum, and biopsy was sent for histopathology. Her symptoms was improved after that subsequently. Acidic fluid was sent, which came to be transudate with negative for skin count, negative for eosinophils, and negative for malignancy.
We don't use any more transudate anyhow. Sac, no sac, high sac. Transudate is an old.
Biopsy was taken, it came to be again normal mucosal, small bowel, and negative for everything.
What facts you mean that? All the pathology?
Yes.
Surgical.
The bowel is surgical.
They resected one. Normal.
Get another pathologist.
No, sir. Was the ganglion okay? The ganglion.
Which ganglion?
The parasympathetic ganglion, the wall of the small intestine.
I didn't.
Is normal.
Why you are asking about the ganglion?
Because sometimes you get like a chalazo, you get a problem with the parasympathetic causing of non-relaxation or something like that. It's rare. But what else do you do?
You probably have part of the sinusitis, part of it, the whole thing, because you get now sinusitis, you get something.
This is still not what to do with this capacity. Is normal candidate surgery. Sorry? Everything is
By the way,
with what? Why immunoglobulin? I'm not sure if we do it or we did it or not.
with that count abdominal pain and sticking that into the regular semen steroids will be the panel was all normal.
Sorry, Dr. Abdullah, why you exclude mesenteric panniculitis? Why you exclude mesenteric panniculitis?
CT scan.
That is mesenteric fat stranding. You said by CT scan.
Sorry?
That is mesenteric fat stranding. It's a picture of mesenteric panniculitis. We can have clinical small bowel and mesenteric fat stranding. This is a picture of mesenteric panniculitis. I know.
help us يا عيال. Yes.
So 2 months later, the patient presented again with the ER with the same presentation, but mild pain now. And CT again shows the same segmental technique of the regional loop with the surrounding fat stranding, which is not typical for ischemic bowel, the acute sending for ischemic bowel, with partial small bowel obstruction. This is her labs during that time.
Go.
So she just gets into
Yeah, because many times she get under
I understand that.
under GS.
Sorry for the
The key GI.
But they involve the GI from the beginning for consultation and scopes and work of the lab.
So the patient was in third class now.
Consult my clinic.
Yes. Live and GD.
There is no fee for putting about
Lid bulge, annual node bulge, diphtheria. FMS.
Without fever, by the way. There is multi now subtype variant. Sometimes you have to.
But could they present with sinusitis, not with my understanding is that there is only, without NGD, small bowel edema, this picture is not, some picture are really people.
And it travel
But usually it's a typical presentation, but they can present like sometimes I do presentation.
Yeah, that's why we
surgical pathology you ruled out this you ruled out IE, you ruled out
topic that we resisted.
Yeah.
Okay, patient was started on steroid, initially with the IV methylbromide with the dramatic improvement in her symptoms. Steroid then was switched to oral and tapered down with improvement in her symptoms. Then the patient was discharged home. During the OPD, patient... Yes. During the OPD visit, the patient was doing much better with the resolution of her symptoms. She was maintained on H2 blocker.
There is a slide, you see. Suppose if it is normal, so you will mind this. Suppose it is normal. From the first one, but this is the time where we request it. Like if you suppose it's normal.
Suppose it does not.
Anyhow, we just request these blood tests and we started with steroid. She do dramatic improvement and she comes following in the clinic now for almost 1.5 years. Sorry? Yeah, she was exposed to unnecessary surgery. Yeah. So the message of, we end up with actually with a presentation of hereditary angioedema. So usually angioedema, most of the time they will have mucosa. Yeah, they will have mucosa swelling, they will have skin allergy. We go back and ask her about this. She's really asymptomatic from the other aspects. So it is a rare form, which is isolated small bowel angioedema. So that's why we presented, just to pay attention to such rare disease. And Iyad probably is going to talk about what's been in the literature.
Yes. About the angioedema, hereditary angioedema, usually presented with this other manifestation like the mouth and the larynx and the lips, but rarely presented with isolated. Few cases only were reported with isolated small bowel angioedema. So just talk brief about the angioedema. So it is self-limited localized subcutaneous or submucosal swelling, which results from extravasation of fluid into interstitial tissue. Angioedema typically affects area with loose connective tissue, such as face, lips, mouth, and throat, larynx, uvula, extremities, and genitalia. A few cases, as mentioned, were recorded with isolated small bowel angioedema with different presentation. So there are two types of this, either upper and lower GI symptom types. The upper usually presented with painful abdominal pain, associated with nausea and vomiting, sometimes hypertension without diarrhea, and the lower type with diarrhea without vomiting. It's difficult to diagnose. We have to exclude everything as we have been done for her. For the management, in the largest series available, 294 patients with recurrent angioedema without urticaria were treated with antihistamine initially, such as cetrazine or disloratadine. For at least 1 month, 86% experienced significant improvement or resolution of the angioedema. For adult patients with angioedema who have infrequent attacks and do not wish to take regular medication for prevention, or those with this frequent breakthrough episode, despite daily antihistamine, the author and editor of the UpToDate, they recommend that to instruct the patient to take 40 milligrams steroid plus 25 to 50 diphenhydramine once during the attack only. But all of these approaches still under trial and still not well formed yet. Thank you.
Thank you. Any question?
I have comment about double balloon, and I think the CT scan didn't show dilatation or significant stricture. I would rather to start with capsule endoscopy, honestly. It's probably safer, and we'll tell you, we'll examine the whole gap. Probably from the start, if there is no significant ulcer, I might avoid double balloon, to be honest with you.
So I think they push for the double balloon because there is radiological finding of the jejunum, there is edema, so that's at that time. No, there was, it was.
It's not the, go back to the small marker.
But the CT.
But we need a small marker. There's not much of Salah mind, which is Ethiopia. So minor proposal for thickening with no evidence structural alterations.
Yeah, they go for that as well.
Yeah, but this is
Yes.
prospectively you have a patient who had abnormal bowel imaging. You'd like to reach that area, take biopsy to know.
But I wouldn't, first I would go to capsule to show me if there is a significant ulceration. Then I might go to retrograde, so to see where is this finding. The distal, the spermiothelium, it's in the proximal jejunum, to at least map it. I think it's a
Service will be the capsule.
It's normal. Why do you have to?
It's normal, the capsule does it. I must go back. Definitely, it's something not really complicated.
Okay.
And I just asked about Benazole. He mentioned.
Yes, Benazole is used usually for the systemic disease, usually with that. But for the isolated small bowel, they mention still under trial, but usually with H2 or H1 blockers and steroids. But for Benazole, usually it's for systemic manifestation.
No, that's why I remember Benazole for one reason. One of our patients like this, and nobody knows what she had. She's with one of our clinic. One day he writes, then Dino. And the pharmacist read it Deno, which is Benazole. She was, and when he started Deno, she was improving. And then he was upset, why you give her Benazole? And then we go back again and see, she's improving Deno. Because it's not. So that's
Thank you very interesting. Yes, we enjoy it very much. And thank you very much for the illustration. Thank you, really. The only comment I will make, not very long ago, I was a medical student. Our professor of medicine told us the following. If the diagnosis is unknown, the best is cortisone, especially in dermatology. So if you have had the cortisone first, you would have to. But of course, this is scientific. You have to know the diagnosis and then.
Okay. Thank you, everybody.
Sure.